Hi, I'm John Gellies from the Corneal Laser Eye Institute in Teaneck, New Jersey. Today, I'm going to be speaking with you about expanding your CTAK practice and how we do education to be able to get more effect within our networks. Few disclosures here. So my background is the director of the Specialty Contact Lens Division of the Cornea and Laser Eye Institute. As well, I'm a clinical assistant professor at Rutgers, New Jersey Medical School. Over the years, I've given about 1,000 hours of CE talks to MDs, ODs, and collaborative care. I've also chaired multiple collaborative care meetings, so we understand the CE process. What I've found recently with CTAK and with keratoconus in general is that there's a lack of awareness. Kind of imagine this as being akin to when we started corneal collagen cross-linking in the US back in 2016. Where we are right now with CTAK is we're at the infancy or the beginning of this, and learning about this and teaching your network about this will help to grow your network. So what we're doing today is empowering you to educate your network. So educational outreach, we really split it into two different avenues here, for providers and for patients. When we're looking at providers, we can do a variety of different methods to be able to reach our networks. We can go with a practice liaison to get in the door. We can do one-on-one meetings with the doctors. We can do CE and educational events, whether those are for credit or not for credit. If we are going to do for credit, we want to be mindful of our legal implications of giving free CE. What we've found is the best way to be able to provide CE for individuals is to go through our local chapters, our local societies. Those allow us the opportunity to put a barrier between us so that we can avoid some of those legal implications. The other one that we can look at is collaboration with industry. So looking at working with CorneaGen or Zemer to be able to provide education for you, get a network together for you, so that you can discuss this with them. On the patient side, emails, brochures, e-blasts, but most importantly, and probably most effective, are the patient testimonials. Patient testimonials on social media can be extremely powerful. If we look at Reddit, these are all over the forums asking, what is CTAK? How has CTAK affected you? Have you had a successful CTAK? These are things that patients want to know, and they're looking on it for the information online. When we look at educational guidance, there are a few different categories that we break this down to. When we look at optometry specifically, they are highly interested in getting approved credits. That's through the COPE system, through ARBO. Generally, you have to apply for these credits, and you have to have a COPE administrator be able to certify your event so that you can give this education. Optometry has a high level of yearly CE requirements, so these are always welcome. Now, when we get into ophthalmology, ophthalmology is less concerned with CE. They're more interested in looking at what's new and what can they learn from. So right now, CTAK being new to the market, this is an incredible opportunity to be able to give these lectures. As far as targeting is concerned, if we are looking at getting specific individuals involved in this, we can give specific keratoconus lectures. When we do that, we incorporate CTAK into the lecture. When you do these sorts of targeted lectures to optometry, what you're going to get are generally optometrists who are interested in cornea specialty contact lenses. They generally will be a good referral network for you, as those individuals work continuously with the keratoconic patient. On the other hand, if you're looking for more broad spread awareness of CTAK, you're going to want to deliver to a more general audience. And the general audience, in my experience, has been interested in cornea lectures, not specific keratoconus lectures. If you focus on corneal lectures, give them information such as managing microbial keratitises, what's new in endothelial keratoplasties and Fuchs dystrophies, and then incorporating a section on keratoconus, this can be very, very effective in increasing the knowledge base and making more individuals aware of this. Now, from the patient side, The opportunities really lie in being able to address their general questions about the procedure. Many of these individuals want to know, will it hurt? How long is the visual recovery? Those sorts of things. The one thing that I can highly recommend, which has been very successful, is doing live meetings with the individuals who have keratoconus in your practice. In many cases, a lot of individuals have not met other individuals who have keratoconus. So this can be a very large bonding and support event that you can create. Now, as far as the educational points that you want to make about CTAK, it's really this, that it is minimally invasive, that is a fully customized procedure that works on an advanced ecosystem where we are delivering care that comes from tomography, the development of your CTAK tissue, to the surgery instruments that you use, down to the femtosecond laser that you involve. When we look at this, the tissue is a sterilized tissue that is a byproduct derived from the development of EK tissue. So we use this residual stromal cap tissue, which goes through a gamma irradiation process and then allows us to be able to use a single donor in 2 recipients, which really honors the gift of donation. Additionally, we really want to tell patients and practitioners that this is really going to provide a meaningful improvement in uncorrected and best corrected visual acuity, as well as many patients meet the criteria for candidacy for this procedure. And more powerful than anything is sharing your patient's success with CTAK. Many individuals, we can go through all the studies that we've done on this, go through all the salient points, but the things that will make the biggest impact are sharing how that individual has had their life changed by having the CTAK procedure. So when we're interested in this, if you are interested in providing CE to your network, CorneaGen will provide assets for your success, anything from slides to brochures to patient-directed information, as well as video assets. Zemer is currently recording this video, which will become an asset that you can use to your networks. Now, how I deliver a lot of this CE is by going through these exact slides during my presentations. So what is CTAK? So CTAK is a minimally invasive anterior lamellar keratoplasty. It's to augment corneal shape, which is therapeutically allowing us to get to improved, uncorrected, and best corrected spectacle visual acuity. When we look at this, the tissue dimensions, the placement are all customized to the individual. When we look at this, this can treat everything from mild to severe cases and can be used in all ages. When we look at visual acuity improvement in these individuals, this was our paper, which was done at our center, a study that was done at our center, where we looked at about 20 different individuals who underwent the CTAK procedure. And what we saw was about 6 lines of improved uncorrected visual acuity, as well as about 3.5 lines of best corrected spectacle visual acuity. Meaningful improvements. Now, when we look at uncorrected specifically, we can see that 16 out of the 21 improved by 4 lines or greater in their uncorrected visual acuity. These are meaningful improvements to these individuals. When we look at manifest refraction, we saw that our spherical equivalent went significantly more towards plano in the direction, ending up at about 1.5 diopters of myopic correction. And when we looked at the topography descriptors here, we can see that we had a significant flattening in mean K, our maximum keratometry, but most importantly is the point of maximum flattening. This is the area of the cornea that we are regularizing the most. And you can see these dramatic effects in the tomography that's shown on the screen here. When we look at this, this is really the most powerful in the images. What we're looking at is the distribution of maximum flattening that we were able to achieve. Now, the reason that this is important is this was tailored to the individual. This wasn't we shoved one size of tissue into the individuals expecting different outcomes. By customizing the tissue to that individual's exact tomography, we're able to titrate the effect to get anywhere from 3 diopters of flattening to 30 diopters of flat, taking care of a broad swath of the keratoconic population. When we look at this, these are just examples where we are able to get 36 diopters of change all the way down to 5 diopters of change to be able to improve the corneal contour. So what are the tomographic criteria for CTAK? When we look at the tomographic criteria for this, the main thing is looking at the location of the keratoconic cone. What we really want for our most ideal candidates are going to be a cone that's located within the 6 millimeter optic zone of the cornea. When we look at this, what we're also looking for is Kmax values that are between 50 and 80 diopters with a best corrected spectacle visual acuity of less than 20/25. When we look at good candidates for this, we can expand our optic zone out to about 8 millimeters or so. When we start to get into caution for the procedure, and this is where it comes down to the surgeon preference and their level of comfort with this, is saying that individuals who have had SMILE or LASIK, we want to make sure that we are underneath that flap or interface deep enough so that we're not interrupting that interface when we're implanting our tissue. The other thing that we want to take some caution with is pellucid pattern keratoconus. Generally, these individuals are poorer candidates. And when we get into individuals who are not good candidates at all, we're looking at individuals who are going to have scarring within the area of the channel formation. We're also going to be looking at individuals who have true PMD and in dense scarring in the central cornea. When we look at these individuals, these are just examples of your ideal corneal tomographies or topographies. When we're looking at educating our network, what we generally do, we'll pass out this as just kind of a pocket guide for them to refer to say, oh, this individual is actually a very good candidate for this. When we look at this, these are the not a candidate topographies. You can see the very intense crab claws, which are getting our maximum points of keratometry outside of that 8 millimeter optic zone. Those individuals are generally poor candidates for CTAK. So how is the CTAK procedure performed? Many of the optometrists, ophthalmologists, and even the patients do want to know how this is performed. Essentially what this is we're getting into the CTAK ecosystem, which involves tomography, femtosecond lasers, Cornea Gen producing the tissue, and Corza Medical providing the instruments to be able to ease the procedure. The way that it works is by submitting your corneal tomography, which can be derived either from the Penacam, the Oculus Penacam, or the Zimmer Galilei. When we do this, we submit that data over to Cornea Gen. Cornea Gen then runs it through a proprietary CTAK software where a customized plan and segment is produced, and that plan is then delivered to the surgeon to be able to make any changes and confirm that they do indeed want that tissue and plan. From there, the tissue is then processed on the Zimmer Z8 laser, which you see right next to me, and that is there to create our customized tissue, which is individually created for that individual corneal tomography. From there, it's packaged, sterilized, and then the surgeon receives the customized tissue, has their plan, and then on the day of their procedure, will use the CTAK instruments from Corza Medical. When we look at this, this is part of the marking system where the individual will use the Corza Medical markers to be able to mark the decentration of where the segment channel will be created. What then happens is we'll go ahead and place our overall optic zone marker, and then using our femtosecond laser, we will go ahead and decenter to our mark. The important thing here is to trust the mark. Make sure that you are offset to the mark, not to the pupil. So when we look at this, what we're going to be doing is opening up the channel and sliding that tissue in. The biggest tip for the surgeons during this is to make sure that you've broken all the adhesions in the channel, as this tissue is soft and will not break channel adhesions for you. Now, once you get it into the channel, you'll use then the CTAK manipulator, which will allow you to go ahead and push that tissue into the channel further and grab the tissue from the opposite side. Afterwards, immediately post-operatively, you can see the dramatic changes in curvature that are created with this. And what ends up happening is the epithelium, as it remodels, fills that depression to be able to elevate that portion of the cornea further, allowing for a smoother central corneal curvature. And these are what the tissue look like about a year postoperatively. This is generally what the tissue also looks at about 1 month. When we look at this, what do we need to know about perioperative care? When we look at perioperative care in this, it's quite simple. The preoperative times on this, what we want to do is take a contact lens holiday so that we can get the most accurate corneal tomographies possible so that our planning is done perfectly. After that, when we are scheduling our patients, we generally want to schedule around 4 weeks out. Generally, it will take around 3 weeks or so for the surgery, for your tissue to be created and then provided. Postoperatively, this is actually very familiar. There is no BCL used, no bandage contact lens, and generally no sutures involved. When we look at this, this is very similar to our co-management of refractive surgery, where we're going to use an antibiotic for about 1 week and taper a steroid over the course of about 4 weeks. When we look at perioperative care, generally on day 1, we're going to see some tissue edema. By week 1, we're going to see that edema has reduced to resolved entirely. And at the 1 month, we'll generally do our refraction and begin the process of contact lens refitting. For these individuals, our post-operative guidance for contact lens fitting is to be able to refit individuals. Because CTAK creates a dramatic change in corneal curvature, any corneal or any lens that is in contact with the cornea will need to be refit. So things like corneal gas permeable lenses, hybrid lenses, soft lenses, and piggyback lenses will all require a refit to now accommodate the new keratoconic shape. Individuals in scleral lenses may not need much of a change to their lens because those lenses are made to vault the corneal shape underneath it. In many cases, they will need, however, an adjustment to the optics, in many cases involving either wavefront guided optics or the use of front surface toricity. Now, any cases to share, this is going to be my most impactful of cases that I like to share. This is an 18-year-old keratoconic patient who has had cross-linking in both eyes. They are struggling with their scleral lenses and unable to function without them. This individual really needs to be able to drive, to get around, to be able to do the profession that he is looking to do. When we look at it, his right eye is limited in the options that are available. He is too thin for anything else other than a corneal transplant. When we look at his preoperative vision, what we can see is his uncorrected vision is hand motion. His best corrected spectacle is 2400 and 2200. And in scleral lenses, he's about 2060 and 2040. When we look at what CTAK has done for him, post-operatively, we can see that his visual acuity has improved from hand motion to 2200 in the right eye and 2060 in the left eye. When we look at his best corrected spectacle in the right eye, he's 2080, and the left eye 2040. When we look at his soft lens visual acuity, because he is now able to comfortably wear a soft lens, he's able to achieve 2050 plus vision on the right eye, 2030 on the left, and with his scleral lens, he's 2030 minus on the right and 2025 on the left, giving him a dramatic improvement in functionality in all aspects of his life. When we look at the benefits to these patients, and this is critical to education, is to mention that CTAK is part of the comprehensive management of keratoconic patients. We need to think beyond just what they can achieve in a contact lens. We need to think about what happens when their contact lenses come out. What happens when they need to wear their contact lenses and they're experiencing complications and can't get away from their contact lenses to be able to allow their eyes to take a break. When we look at this, these are hugely impactful for patients. Additional cases you can see here, going from uncorrected vision of 2100 and 2040 in spectacles to 2025 uncorrected and best corrected spectacles. When we look at these, we can see dramatic changes all the way through and the ability to maintain vision in their contact lenses. This allows them to gain when they're not wearing lenses and not wearing spectacles. And with that, I'll thank you for your time, and any questions we'll be happy to take. Thank you very much.